of the vessel.
Yeah, agreed.
Dr. A.K. Banerjee.
Another thing is it assesses the oscillation. If his oscillation is significant, it
I
to
feel
do
we
it.
should discuss what is scientific. That's the point. Just dilating and getting away with a good result is not the point. What are you doing for the long-term recurrence? Do you have a strategy to prevent long-term recurrence? Is the issue.
Okay, thank you very much. I think it's time to start the next session. I now request Dr. M.K. Das to come and deliver his talk. Is he here, M.K. Das? Yes. Can I request Dr. A.K. Banerjee to come to the dais to join us as a co-chair?
So good afternoon, everyone. Thanks to the Scientific Committee Chairman, Dr. Srinivas, for giving me the chance to speak on this subject, which is a quite tricky one while treating a patient of atrial fibrillation with CAD or vice versa. So my topic is triple or dual or NOAC, which is the best way to treat atrial fibrillation and coronary artery disease. In the left panel, there is the cartoon to show what are the sites of different molecules like warfarin acinocumarol acting on the tissue factor via the vitamin K, rivaroxaban, apixaban, edoxaban on factor 10A, dabigatran, thrombin, and similarly, ticlopidine, clopidogrel, prasugrel, ticagrelor are acting through ADP, and aspirin, of course, through the COX inhibition, and ultimately all acting through the fibrin and the preventing the thrombus formation. So there is a very high chance of developing atrial fibrillation to the tune of 41% in a 70 plus years person, and it increases with the age, as well as not only the atrial fibrillation, but also the different kinds of the coronary artery disease, whether it is unstable angina or stable angina, the chance of developing atrial fibrillation is high. But there are unmet needs in the management of patients of atrial fibrillation undergoing PCI. 20 to 30% of patients with atrial fibrillation and an indication for continuous OSA have a coexisting CAD and therefore may require PCI. An estimated 1 to 2 million anticoagulated patients are candidates for PCI procedures, and stenting requires follow-up treatment with antiplatelets, which puts anticoagulated patients at higher risk of bleeding. And there is the need of optimal management of atrial fibrillation undergoing PCI atrial fibrillation. In atrial fibrillation, as in active trial, the combination of aspirin and clopidogrel is not as effective as OSC, especially in patients with atrial fibrillation. However, the stenting, in case of stenting, the combination of aspirin and thienopyridine is more effective than warfarin in patients with coronary stents. And you can see the effect of the two kinds of treatment. On one hand, the oral anticoagulation is superior in prevention of the thromboembolic episodes. On the other hand, when there is a dual antiplatelet, that is superior in prevention of the thrombotic phenomenon in the stents. And DAPT is not enough in this cohort. OSC needs to be added in patients of atrial fibrillation. And that's called the triple antithrombotic therapy, which is dual antiplatelet therapy plus oral anticoagulation. Now, patients on OSC, as in AF, when DAPT is added, actually the chance of developing bleeding complication is 2 to 3-fold, and that is the high risk group of patients. And associated with the bleeding, there are so many complications or so many happenings which can be there, shock, anemia, etc., and that increases the chance of mortality. And we need to balance. This is a condition like between the Sheila and Charybdis, and we need to balance between the two. But while balancing, we need to identify clinical and procedural factors associated with increased ischemic risk or bleeding risk. And similarly, you have to manipulate the duration of therapy in a particular setup. Now, increased ischemic risk or risk of stent thrombosis occur in these few conditions: advanced stage ACS presentation, multiple prior MIs, etc. And increased risk of stent thrombosis occurs in this particular cohort of patients. Similarly, the various kind of bleeding risk is associated with the history of prior bleeding, oral anticoagulation therapy, female sex, advanced stage, and CKD and all. So you need to balance between the two. Antithrombotics in PCI with atrial fibrillation, we need to balance the combination as well as the duration, and these are some of the trials which are showing the different kinds of results, like in West trial, OSC plus clopidogrel associated with significant reduction in bleeding and no increase in thrombotic events versus triple therapy with OSC plus clopidogrel plus ASA. Similarly, in COMPASS trial, also there was the combination rivaroxaban plus aspirin had lesser cumulative risk as compared to rivaroxaban alone or aspirin. Same way in the Pioneer AF-PCR trial, as was highlighted by Dr. Sharat Chandra yesterday, that the low-dose combination with the rivaroxaban plus PTY2 inhibitor for 12 months has got the lesser chance of developing cumulative risk in patients of atrial fibrillation with PCI. Another trial that has been also highlighted earlier, REDUEL PCI, where again dabigatran was combined with P2Y2 inhibitor in 2 doses versus the warfarin plus P2Y2 inhibitor plus ASA, that is the triple therapy. And both the arms showed efficacious results in terms of non-inferiority versus the triple therapy with triple therapy when the dabigatran plus Y2 12 inhibitor were considered. And this is the better result in terms of reducing the complications or major adverse cardiac events. There are basic difference between the two trials, REDUEL PCI and Pioneer F-PCI, and it is in case of REDUEL PCI predefined in each triple therapy. The duration was predefined, but in case of the Pioneer AF-PCI, the duration was as per the investigator's discretion. So there was no significant difference in bleeding outcome. It was either non-inferior or superior. So there was desirable safety or efficacy outcome over a period of extending from 1 month to 30 months, depending on the thrombotic and bleeding risk. These are some of the standard slides for the indications and duration of the DAPT. I'm not going into the detail of it, but definitely the duration of triple and single or dual or single therapy have become have been put forward in the various guidelines. The basic principle is that whenever there is more chance of developing bleeding, then you reduce the duration of the treatment to 1 month to 3 months, and then continue the OSC plus single antiplatelet agents up to 12 months, and after 12 months, you just continue with the OSC. Similarly, in the highly thrombotic groups, with lesser bleeding chance, you increase the dose, continue the OSC plus DAPT to around 6 months, and then go with the OSC plus single antiplatelet agent, and then after 12 months, you continue with the OSC alone. Similarly, the ESC guidelines have been also talked in the same way, and with AF patients needing OSC after elective PCI with stent with higher risk, again, the same kind of principle will continue. with the dual antiplatelet for some duration, so for the lesser duration with OSE, and then increase, stop one of the agents and continue with the OSE plus single antiplatelet agent for 12 months, and then only OSE after 12 months. There are certain measures to mitigate bleeding in patients on DAPT plus OSE. These are all known to you. I'm not going in to highlight further, but it refers to the techniques as well as the use of the NSAID, not to be used in particular group. We use the PPI so that the bleeding in GI does not happen. And also in CKD, you have to take care with particular agent and how much is the dose to be determined. There are certain antidotes also. And to summarize, and the carry-home message is that during the peri-PCI, OSE, possible a period of washout is preferable, and bridging therapy is often unnecessary. Urgent or emergency procedures should not be delayed due to anticoagulation, and rarely is reversible or anticoagulation necessary. Similarly, post-PCI, OSE, either VK or NAOSE, may be considered taking physician and patient preference into account. If VK is chosen, maintain INR between 2 to 3. If NOS is chosen, use lowest therapeutic dose and maintain OSE lifelong. And so far the antiplatelet agents are concerned, minimize the DAPT duration, including low-dose aspirin and clopidogrel, and avoid prasugrel or ticagrel, or initiate single antiplatelet agent, preferably clopidogrel, as early as possible based on ischemic or thrombotic and bleeding risk profile of the patient. Discontinue APT for by 1 year in most of the patients, and maintain on SAPT only in patients at high ischemic or thrombotic risk and low risk for bleeding. So that's the situation of the Sheila and Charybdis to be taken into account while treating a patient of atrial fibrillation with CAD or with or without PCI. Thank you very much for patient hearing.
Thank you, Dr. Das. I think it has been a difficult decision whether to have a dual antiplatelet therapy or a triple therapy. I would excellently summarize the whole issue. Can we have the next speaker, Dr. Sharat Chandra from Lucknow? Is he around? Yep. He's going to tell us more on optimal anticoagulation for patients with STEMI. What should be the standard of care in 2018?
Good afternoon, everybody. My topic is optimal anticoagulation for patients with STMI. What should be the standard of care in 2018? So, in anticoagulation, everything starts with unfractionated heparin, because this is the most affordable, oldest drug, most used drug, preferred and highest class of recommendation by both ASC and ESC because of the common practice. So these are all old trials with heparin published in all 1992, 1994, and that's the meta-analysis which was published in 1992, which stated that intravenous heparin should be given to patients treated with hypnotic agents for acute myocardial infarction. But there are certain disadvantages with heparin, like it has a narrow therapeutic window, it has high variable dose response relationship, reduced ability to inactivate thrombin bound to fibrin, hit heparin resistance, and prothrombic state after discontinuation of unfractionated heparin. So coming to the new drug, that is another drug that is low molecular weight heparin. It consists of fragments of unfractionated heparin with a mean molecular weight of 5,000. Advantage with low molecular heparin is that it produces a more predictable anticoagulant response and has a longer plasma life. It has a greater bioavailability. The incidence of it is low. And the most important thing is convenience, because it is more convenient to use than unfractionated, and this factor alone has led to the widespread use of LMWH in both arterial and venous thrombosis. These are all old trials with low molecular heparin published in 2002 and 5, and these were the these are the trials with when low molecular heparin was compared with unfractionated heparin published in 2003 and 5, and that's the meta-analysis of in 2005, which stated that low molecular heparin given for 4 to 8 days compared with placebo reduces reinfarction by approximately 1/4 and death by 10%, and when directly compared with unfractionated heparin reduces reinfarction almost by 1/2. So this is the trial Atoll 4 trial in which enoxaparin was used in primary PCI, and this trial showed that secondary endpoints were significantly decreased with enoxaparin, and there was a reduced rate of bleeding also. So this is another drug, fondaparinux, is a synthetic pentasaccharide, selectively binds antithrombin and cause rapid and predictable inhibition of factor 10A. Is an indirect inhibitor. And the major trial of fondaparinux was OASIS 6 trial, in which fondaparinux reduced the rate of death and bleeding in overall study population, but it showed an alarming rate of periprocedural catheter thrombosis, new acute thrombosis, and no reflow. So it's now a class 3 recommendation in STMI and should not be used. Coming to the bivalodin, this is the first large trial of bivalodin Horizons MI, which showed that MACE and NACE are significantly decreased with this drug. Bleeding events were reduced, but there was alarming rise of stent thrombosis. That was acute stent thrombosis, which was 4 times higher, but the overall rate of stent thrombosis was same. Then again, there were different trials of bivalodin, like important trials of like Euromax, PPCI, Bright, Brave, and Matrix. These all trials showed different results. The last 2 trials were Matrix trial and the Sweetheart Validate trial, which showed that MACE and NACE were not significantly different with these drugs. And the summary of bivalodin from different meta-analysis is that these bivalodin have demonstrated no mortality benefit over, but fewer bleeding complication in bivalodin users. And observed benefit of bivalodin in reducing events was postulated to be associated with use of GPI in the control arm, because GPI was used more frequently in the control arm. And increased rate of stent thrombosis is most likely related to the short half-life of bleeding, because in that period there was no sufficient production because when ADP receptors have not been effective. So because of these last 2 trials, Matrix and Sweetheart Validate, bivalodin, which was earlier class 1 indication in 2003 guidelines, it is now 2017 guidelines, it is now class 2 indication in primary PCI. New oral anticoagulants which are tested in ACS are like apixaban, rivaroxaban, direxaban, dabigatran, and 2 PAR antagonists like varoxapar and enoxapar. This is a trial with apixaban, APRIS 2 trial, and the important highlight points in for APRIS 2 is the addition of apixaban to contemporary platelet therapy increases major bleeding without any significant reduction in ischemic events in high-risk patients following an ACS. And study was terminated early due to concern over increased bleeding. And the main point in this APRIS 2 trial had older patient, more stroke patient, and they had more comorbidity like diabetes and renal dysfunction. There was, and the anticoagulation which was tried in this trial was high level because the dose of apixaban was used, which was used in this drug, was as same as it was used in AF. Then again, this is the important trial with rivaroxaban, Atlas ACS 2 MI trial, in which rivaroxaban in 2 doses, 2.5 BD and 5 milligram VD were given in the ACS group, and that's the sub-study of Atlas ACS 251 in which in STMI patient, in which rivaroxaban had shown benefit in all-cause death and death from cardiovascular diseases. And the important summary from Atlas ACS to me is, there was a dose-dependent increase in bleeding associated with rivaroxaban, and TIMI and major and myelin bleedings were higher with rivaroxaban, but there was no significant difference in fetal bleeding compared to placebo. And cardiovascular and all-cause death were reduced for both rivaroxaban dose combined and for the 2.5 milligram PD dose. Again, this is again important trial, Gemini ACS 1 trial, is the phase 2 study in which low dose rivaroxaban was compared with aspirin in addition to P2Y12 inhibition in acute coronary syndrome. And the basics for this Gemini ACS 1 was as triple antithropic therapy with DAPT plus rivaroxaban has been shown to reduce cardiovascular event, but with a significantly higher rate of major bleeding complication. And in vivo thrombosis and blood bleeding studies have demonstrated that rivaroxaban with P2Y12 inhibitor had similar efficacy to DAPT, but with a lower risk of bleeding. So the important salient point from this trial is that in this phase 2 trial, there was similar risk of TIMI non-CABG clinically significant bleeding with combination of rivaroxaban twice milligram daily and with a P2-IL inhibitor, either ticagrelor or clopidogrel, compared with DAPT, aspirin plus clopidogrel or ticagrelor. And the ischemic outcomes were also similar, but trial was not powered for assessing this endpoint because it was a phase 2 study. Overall trial suggests that use of low dose rivaroxaban with ticagrelor without aspirin was associated with an acceptable safety profile compared with DAPT and with aspirin and the ticagrelor. This is the only trial which tested the combination of ticagrelor plus rivaroxaban in ACS patients. That's again a new drug is Direxaban factor 3 and A inhibitor, which has been tested in Ruby 1 trial. But in this trial, the bleeding rates were numerically very high in all Direxaban arm. So the development of this drug was halted after Ruby 1 trial. And again, important trial is Redeem trial, in which dabigatran was tested in ACS patient in 4 doses, 50 milligram, 75, 110, and 155 milligram BD. And the important salient points from this trial is that there was overall low bleeding rate with dabigatran, and there was bleeding rate is dose dependence, and there is only less than 1% absolute increase in major and severe bleeding with dabigatran in the dose of 110 and 155 milligram PD, and there was significant reduction in coagulation activity that was assessed by D-dimer, and which was without dose relationship. And dabigatran was not associated with any ischemic benefit, but there were overall low numbers of clinical endpoints in all treatment arm. So the implications of Redeem trial are dabigatran up to 150 milligram BD on top of dual antiplatelet therapy can be used with modestly increasing bleeding risk, and Redeem support the rationale for evaluation of the 110 and 150 milligram dabigatran doses on our clinical outcome in ACS patient in a largely adequate powered study. So again, this is a PAR receptor antagonist. One is this is Varoxapar, which has been tested in Tracer trial, and it didn't show there was no decrease in the composite of cardio death and MI, stroke, hospitalization, ischemia, or revascularization, and there was significantly increased bleeding, including major bleeding and intracranial hemorrhage that led to the premature termination of this drug. This is Varoxapar, and another important trial is Atopaxapar, is tested in Lancelot ACS, and this is the favorable trial. Atopaxapar appears a novel anticoagulant which does not appear to increase major bleeding and may improve clinical endpoints. And this is the new drug, Otamixaban, is a factor 10A inhibition parenteral drug tested in Sapphire trial, and that was the Sapphire trial was the phase 2 trial, and next trial, phase 3 trial is the Tau trial, and which showed that compared with unfractionated heparin and Eptoide, Otamixaban were not superior, as it did not reduce the risk of ischemic event in a ST patient managed with invasive study, and the risk of major bleeding were approximately double, and thus so this trial was negative trial. So to conclude, these are the 2017 guidelines regarding ST elevation MI. Routine use of unfractionated heparin is still class 1 indication, and in patient with HIT, the belvedere has indication of class 2A, and the routine use of enoxaparin and belvedere is class 2 indication. And that's the new addition to the guideline is of rivaroxaban, which show in 2017 guidelines. It shows in low bleeding risk patient who receive aspirin and clopidogrel, low dose rivaroxaban, that is 2.5 milligram BD, may be considered. It's now a class 2B indication. Thank you.
Thank you, Dr. Sharat Chandra.